Well, I'm going to talk a little bit now about the benefits and risks of surgery, because I think this is the essence of the whole process of hip replacement. Obviously, we've already mentioned the sort of indications for hip replacements, which are pretty severe pain, functional deterioration and stiffness, and this obviously causes limitations and affects quality of life. And therefore, let's first of all talk about the positives. What are we hoping to achieve with a hip replacement operation, whether it be partial resurfacing or total? Well, the main goals are to significantly reduce the pain. I think that's pretty self-evident. And in most cases, we can eliminate pain. I hesitate slightly there because it's not uncommon to have some tenderness or discomfort, and a little bit of groin pain occasionally after the operation. But pain relief is certainly one of the goals. The second goal is actually to reverse the other bits of the equation, that is have better movements. Now, in some cases, some arthritic hips are very, very stiff, which cause marked restriction. So we will improve movement in those cases. In other types of arthritis, perhaps the restriction isn't so obvious, but hopefully movement will be improved. But the third area is function, improving walking distance, but also walking speed. And many patients tell me prior to surgery that they can walk a distance, but they walk at a snail's pace. And they're really impressed after the operation. Their stride is better, and their cadence or walking speed is better as well. So mobility is improved, and all aspects of daily life are improved. And I often tell patients that it's not unusual for patients who have a successful hip operation to be normal for their age. So for most patients, it's a sort of operation which can substantially eliminate pain, that improve mobility, improve function, and allow them to live a life for their age. And if that involves playing golf or doubles tennis, that's the sort of functional activities they can achieve. Now, in some cases, patients want to do a lot more than that, and I think that involves a discussion with your specialist as to whether that's wise or sensible or realistic. Well, I think we all know that there are potential risks of any surgical intervention. I think it's very important to make this point without wishing to over-exaggerate or worry. Now, risks are often put into two groups: general risks and specific risks related to the joint. And the general risks may involve chest infections, it may involve risks of other medical complications, heart attacks, strokes, and those risks are really quite small, 1 in 1,000 or less. Of course, the worst risk obviously is loss of life or mortality, and most studies have shown that those risks are very low without being zero. And the sort of mortality risk that we're looking at in elective orthopaedics nowadays is in the region of about 2 in 1,000, between 2 and up to 4 in 1,000, depending on the precise time period considered at risk. But most studies have shown that the increased risk of mortality in the first 90 days of surgery, and after that, any additional risk then goes to the background risk for your age. Now, if we move on to other general complications, then obviously there's a slight risk of chest infections. If we now move on to more local risks of the joint replacement, then I think one of the more serious risks, and certainly a risk that I worry about and want to minimise, is that of deep prosthetic infection, where unfortunately the joint replacement becomes infected. And the risk of that is in the region of 1 in 100, but can be slightly greater or slightly worse than that. And that's the risk normally in the first year of surgery. If an infection does occur, it normally comes to light within the first 6 months and is normally associated by the pain not going away, the function not improving, some redness and persistent pain. And in the extreme, you can develop a sinus or hole where the infection drains from inside to out. Now, surgeons try and reduce that risk by using prophylactic antibiotics, operating in clean air enclosure, and so-called spacesuits or gowns, which create the maximum protection of the patient from the surgeon. Because people say, where does this infection come from? The most common source is from the patient's own skin, but can come from the surgeon or the air environment. Those are the three areas. So having considered deep infection, there's a problem of superficial infection, which is different. Obviously, it just occurs in the skin. And the risk of superficial infection, depending on definition, may be as high as 5%. And there are different stratifications of diagnosis, but it should be fairly low. And just if you develop a superficial infection, it's obviously worrying. It doesn't mean to say you can develop a deep infection. And indeed, it's very difficult to be precise as to what is superficial and what is deep. And perhaps that's another topic of a seminar rather than a quick interview. Other complications is that of a dislocation. A dislocation, obviously, when the hip comes out of joint, and it's a very distressing and worrying complication. It can occur unexpectedly, often when the advice from the therapist has perhaps been forgotten, stooping down, getting out of a chair, putting shoes and socks on. It commonly occurs if it's going to happen in the first 6 weeks. And the hip comes out of joint. Unfortunately, it can be painful. It's very, very distressing. And often it means a 999 call, going to the local hospital to have the hip put back in. Now, there are other complications. You drill into the small print stuff which are concerning. One complication is limb length discrepancy, and particularly lengthening the leg. You may say, how can that occur? But it can occur. It's not uncommon to get slight differences of limb length pre and post-op, and differences within about ½ an inch or 13 millimetres are often not a problem. It may be discernible immediately, and there's often some worry about this and concern, but in my experience, the vast majority of these minor limb length discrepancies settle down, and after 3 months, the patient's forgotten about it. But just occasionally, the limb length can increase above ½ an inch, and that can be more persistent. And the risk of significant limb length discrepancy may be in the region of 1%, but again, the data is very, very imprecise on that area. Other complications, quite serious, would include nerve injury, the sciatic nerve, which provides sensation and motor function to the foot, or femoral nerve injury, which causes function to the knee extension. And both of those injuries can have pretty devastating effects if they occur. But thankfully, the complication of those, the chance of that complication is relatively low, certainly well less than, one in about 500 or so. Although transient sensory changes are much more common than that. So I would distinguish between more persistent and transitory sensory changes that occur in the first 48 hours of surgery. Obviously, vascular injury can occur. There are vascular structures around the hip. The profunda femoris artery can be damaged. Hopefully that is a rare complication, but can be serious and cause significant bleeding. And often also venous damage can occur after the operation. Other complications include embolization and deep venous thrombosis. Deep venous thrombosis is a blood clot. It can occur in the calf. It can occur more proximally in the femoral vein, or it can occur in the pelvis itself, an iliofemoral thrombosis. And minor blood clots are not uncommon. Below the knee, they're often asymptomatic, but above the knee, they can be symptomatic, causing very marked swelling of the leg and distress and pain. It's a very hot topic. Most surgeons will give some agents to protect this. This could be a mechanical agent, a foot pump, to allow external compression and movement of the muscle to facilitate venous return. Or it could be combined with chemoprophylaxis. It may be an injection, a heparin type material, or it could be a tablet. And there is a trend to use these agents now of extended period of up to 30 days or even slightly longer. Although the use of these agents are controversial, and some surgeons say, I don't like using chemical agents because they cause problems with the wound. They can cause bleeding into the wound, and that's a problem in itself. So there's a balance, and most patients will be risk assessed by the surgeon or the surgical team to decide what is the best protection for you. Patients should be warned that some amount of leg swelling is very common, because if surgeons don't advise them, it can cause distress, and it is variable. Some leg swelling is quite common. It could obviously be the foot or the ankle, but in some cases it involves the calf. And most people think, I have got a deep venous thrombosis, and it's not often the case. And this is a reflection of the operation and the interference with venous return and other factors which cause persistent swelling of the leg.